First of all, I would like to thank the organizers and Professor Jagannath for inviting me to deliver this talk. And I bring greetings from Nimhans. And as I can see, our director, Madam was also present yesterday, and several of the alumni and my teachers are also there in the audience. My task is to kind of give you an overview of this complicated topic about which we are still learning. And my previous two esteemed speakers have already given you a perspective about what deep brain stimulation is. So, from a neurologist perspective, so you have to understand for all the students that we all work together. We have to work together, and when different specialities come together, then there's a lot of knowledge transfer which happens and lot of new things come up. So in this speciality where deep brain stimulation is involved, neurologists, that is physicians and surgeons, have to come together along with several other streams like speech pathologists, for example, psychiatrists. They all have to come together to manage these patients, and it's a combined team effort for the best outcome for the patients. But without technological improvement, it would have never been possible to achieve what we have achieved in this specialty. So first and what I will do is I'll just cover some of the what is neuromodulation and evolution of DBS, which already has been covered partly by my previous speakers, and then I will cover about movement disorders like Parkinson's disease, dystonia, tremors, Tourette syndrome, and other new developments. So for some of you, it may be very novel thing. What are movement disorders? So names I have already put in: Parkinson's disease, dystonia, tremors, Tourette's, and other disorders. Now, the term deep brain stimulation, as you know, is deep brain. So it is deeply situated inside the brain. Whatever we are doing is we are trying to stimulate the deeper structures which are located. And these are the deeper structures which are in this diagram you can see. So the Dr. Praveen had previously shown about the subthalamic nucleus, which you can make out that it is located quite deep in this part. And to reach accurately this part without damaging any of the structure in between or disrupting any blood vessel or causing paralysis is a real feat in itself. And this has been made possible by technology. So what are movement disorders are listed below. Either the movements can increase, that is tremors can happen, or dance-like movement, that is chorea, can happen, or twisting movement, if you would have seen, the dystonic movement can happen. Or hypokinetic is where Parkinsonism can happen, that is reduction in movement, that is paucity in movements, and Parkinson's disease is a classical example. How evolution has occurred, briefly I will cover this slide I have taken from one of the seminar of a neurosurgery resident, and she has tried to cover in this slide how deep brain stimulation surgery has evolved over the various decades in last 60 to 70 years. From the beginning, when Sir Victor Horsley and Robert Clark actually did some basic first studies in monkeys and tried to establish how to reach the deeper structures in the brain, and then subsequently Aubrey T. Mewson, he devised the earlier frames actually for accurate surgeries, which have been covered by a previous speaker also. And you can see the different the atlas which is followed now. Several atlases are available for exactly knowing the anatomy of the brain, and these are the various other scientists who have contributed. Professor Narabayashi, then Lars Lexell, who has developed the Lexell frame, and this is the one which has made a significant impact so that accurately we are able to reach the particular target. Then Irving Cooper, and you would be reading about these scientists in your textbooks also. And it was Alim Benabid actually who first DBS was done by him successfully in a patient with tremor and Parkinson's disease, and subsequently it became very much spread around over the whole world. So this is the timeline, as you can see, from the development of the stereotaxic frames. Then there was a very interesting, in 1963, Delgado uses a stimulus to wirelessly inhibit aggressive behavior in the bull. So way back in 1963, in animal experiments, it has been tried that behavior even can be inhibited. And then subsequently, as the technology advanced, the battery technology, lithium batteries in 1980s, initially 2 batteries were implanted, and then subsequently a single battery, then different type of electrodes, rechargeable DBS batteries became available in 2009, and then closed loop DBS in 2013, and directional leads, which Dr. Praveen also alluded to in the previous talk, have come up most recently. And now we are going to the era of closed loop DBS, which I will tell later. So these are the 3 components: that is a battery, which is known as implantable pulse generator, a lead which goes, then the extension, that is wherever the target is there, the current is being delivered at that particular place. Several theories have been put forward, but clear cut, there are, we do not know how it inhibits, but basically a current is delivered at the target site, and if that target site is controlling a particular thing, for example, it comes under the tremor loop, so it is going to inhibit a tremor. If it comes under the rigidity related loop, like subthalamic nucleus, so then the rigidity, tremor, both may come down. So in that way, for even psychiatric indications, several in memory related issues like nucleus accumbens, it is being tried in several of but the principle remains the same, that we are stimulating that particular part. And like we all have a particular voice of speech, like for example myself or you, everyone can be identified by their voice. In the same way, in the brain, each particular part of the brain has its own frequency of firing. So when we go from, for example, basal ganglia, different structures, globus pallidus to substantia nigra, then the frequency of firing is actually, we can hear that, and that helps us to identify whether we are at the correct place or not. So this is for simplicity, this is what we can understand. And down you can see that if you can see, these are the dense red lines show that at 0 volt, means when the stimulation was not there, then the neuronal firing pattern is quite high. And when 3 volt stimulation is given, it completely subsides. So electrical current is being used to suppress the firing at that particular location. So this is the most basic explanation. And now the advancement, like in your mobiles, if you see, initially we had to charge for for battery life was very much shorter. Now the battery life is increasing. So the biggest challenge in deep brain stimulation, which I can see from Indian perspective, is the battery life, which used to be very short, like 3 to 4 years the one battery used to drain off, and that was costing around 6 lakhs. So that was causing a recurrent cost. Now the batteries, advancement in battery also has occurred, and now the battery life is almost 15 to 25 years. So these changes also technologically are responsible for significant changes. And these are the different batteries which are commercially available, means based on the manufacturer, Medtronic. And I would like to say that none of this technology has been indigenously developed. So if you want to take it up in your future career to develop indigenous electrodes or indigenous technology, it will bring down the cost of this therapy to the patient significantly. Currently, all of this is imported from various other countries. And these are the different frequencies. So as already told, the frequency, pulse width and voltage or current, this is what is the main thing that we all try to change around for stimulating the brain. And this is just to show that these are the leads. And interestingly, these leads are made of platinum iridium with nickel alloy. So this is platinum iridium is inert with good electrical properties and has low impedance. That is why it is used in all these electrodes. And these are the various electrodes, circular, and currently what we are seeing is the newer ones where we can stimulate. For example, if I am standing over here and I want to stimulate my right side selectively, So I can actually, the current can be channeled in such a way that the current is only focusing on the right side. So in a brain where there are several tight structures there, we just want the current to go in the place where it should go, not go to the other places, because it can cause side effects. So these are the technologies which are now available, so that we can steer the current in right side, left side, or so four directions can be used, and that actually helps a lot to reduce the side effects in the while stimulating. Because if you see, the subthalamic nucleus is located at very critical places. If the current spreads, then patient may develop weakness or may develop even dystonia of the hand, and also unwanted side effects. And these are the various leads which are developing, and ultimately you will find that the black area which is there, from that the current is transmitted to the surrounding areas. And this is the type of current which area which is produced. So previously it used to be circular, and as I told, it can be steered towards right side. For example, you see this is a little bulged towards this side. So obviously the side effects will be less in this type. And these are just to show that if we do the X-ray, how this appears. And these are the different firing patterns. As I told you earlier, when the lead is passing through the various structures in the brain, each cluster of neurons fires in a different way. So we identify when we have reached STN by a typical firing pattern, which you heard in the last lecture by Dr. Praveen. And when we reach substantia nigra, the pattern of firing as well as the screen changes. So what are the indications of deep brain stimulation surgery? Parkinson's disease, you can see tremors, and you have to understand, first medications are tried. Tablets are tried by physician. When it becomes refractory to all, or in advanced Parkinson's disease, then only surgery is advised, because there are side effects and complication chances also. So these are all refractory cases. Selection criteria, we have to be careful, because the correct diagnosis should have been made. Like Parkinson's disease, age, higher the age, the complication chances are more. The duration of disease, like if the longer disease duration in Parkinson's disease, there is a window period during which it will be effective, otherwise it may not be that effective and the results may be poor. And then other things, cognitive status, if there is poor memory status, then these patients are not taken, because one of the side effects of STN is also cognitive decline. Then psychiatric problems, social support system, these all things are kept in mind while operating these patients. And what things improve? Tremor improves in Parkinson's, stiffness improves, fluctuations, the number of tablets, they come down, and also the off and on phenomena. What happens is, when the patient takes the tablet, patient is all right for 3 hours, then again worsens. So these all things are almost improved, because it provides a sustained dopaminergic stimulation. And then who are less likely to improve with this? Those who have autonomic dysfunction, like blood pressure fluctuation, or memory issues, hypophonia, speech will not improve, and depression, severe depression, or not Parkinsonism. That is, they look like Parkinsonism, but they are Parkinson's disease, but they have atypical Parkinson's. And the best patients are patients with advanced Parkinson's disease, and patients are selected very carefully by a team of, I told you, like physicians, surgeons, and a team who will give the clearance for all the other parameters. So this is the just protocol I have mentioned, which we follow. After that only the patient is taken in for surgery. What is the suitable age? There is no specific age cutoff, but the chances are better when the patient is younger. And absolute contraindications, I had mentioned a poor levodopa response is very important, and other are relative contraindications. So what are the targets which are used? So these are the various. Subthalamic nucleus is the commonest, as told by Dr. Praveen, and then ventral intermediate nucleus if the tremor is more, or for the tremor, zona incerta and globus pallidus interna. And this is the subthalamic nucleus. As you see, it is a very small structure, but it has lot of connections. So we can get several. We have to stimulate, and programming has to be very accurate, because all these motor connections are there, associative, limbic, internal capsule, several critical structures are very close to the subthalamic nucleus. So I'll show you some of the videos about how the patients were before surgery and after surgery. This is pre-op with off medication. So first and foremost, we check the patient without medications, keep the patient 24-hour off all with the medicines, and then see if you can see severe slowness is there. Patient is walking very slowly, and a freezing of gait is occurring. This we do in off state because DBS gives almost similar response as levodopa, and you can see the patient is unable to almost take any step. And this is the pull test which we do just to look at the balance capacity of the patient. And then the on state, if you see what happens during on medication, all the improvement has occurred. So this is a good candidate for surgery. Okay, so this is the same. This is the patient before surgery with severe tremors. So the previous video was of a patient with who is eligible for surgery, and this is, for example, a patient with severe tremor predominant Parkinson's disease. And after surgery, you can see there is significant improvement in slowness. Tremor has disappeared with the programming as well as the brain stimulation surgery. And these are some of the studies what we have found different as compared to the Western data. Western data, the age of onset of Parkinson's disease also has been shown almost 1 decade later, what we have found. And similarly, the usual DBS that we have done is also in a younger age group as compared to. And these are some of the papers in which we have also tried to highlight that choosing the patient carefully is very important in the beginning, because several patients may look like Parkinson's, but they are not having Parkinson's, but maybe genetically mediated or some other variants. And these are the other papers. This is one unusual case which I will show you, which we did for a dystonic camptocormia in a patient. So this is a type of dystonia. And here you can see there is a patient is bending forward because of the dystonic spasms in the anterior part of muscles. And we did globus pallidus interna DBS, and after 7 years the patient is able to walk straight almost. He was having a lot of difficulty in walking straight, and he had significant issues in maintaining the jobs. Then coming on to the tremors. Tremor classification I have shown over here. But overall, you should understand that there is essential tremor and there are several other tremor syndromes. Essential tremor is very common, but it is not Parkinson's disease. The most important thing, why? Because several youngsters come to us saying that I have Parkinson's, then we have to reassure that it is only essential tremor. And several stages are there in treatment. And finally, if it is refractory to treatment, then we give the DBS option. And this is a patient of essential tremor, slightly asymmetrical, and you see when the DBS is not working, you can see how much is the tremor. So patient has difficulty in drinking water, shaving, and doing activities of daily living. And then he's just trying to show how difficult for him the movements are. And the following, switching on the DBS, you can see completely the tremor has disappeared. So this is the dramatic improvement which can happen in patients who are suitable candidates for deep brain stimulation. And this we have reported the rare cases also in this paper, in 17 cases. What about dystonia? Dystonia is a movement disorder characterized by repetitive, abnormal, twisting kind of movements. And I'll show you videos because I have less time. Here also, if chosen correctly, dystonia responds dramatically. This is one condition known as DYT1 related dystonia. So it is childhood onset severe generalized dystonia, and these patients are actually they succumb to several complications, and but genetic diagnosis, once it is confirmed, and you can see how severe dystonic spasms are happening in his whole body. This is also known as dystonia musculorum deformans, which is earlier. And post-operative, after DBS 2 weeks, you can see at least he is able to walk with support, and after 3 months he is able to walk completely without any abnormality. So DYT1 related dystonia responds very nicely to the DBS. And then there is another patient who was referred for many years. He was treated as psychogenic dystonia and he developed contractures. He was also found to have DYT1 dystonia, and then you can see the different problems which he was having. He had developed scoliosis also, which was actually not correctable. And 3 months post GPI DBS, you can see he is stable. There are no dystonic spasms in the body, and he is able to do most of the activities and walk also, except that the spinal deformity has not completely improved. Then coming the tic disorders. Tics are, the classical example is Tourette syndrome. So in Tourette syndrome also severe uh, Tourette syndrome, which is refractory to all the tremors, DBS can work significantly, and this is one of the patient who was referred, college going student who has severe Tourette syndrome, and he responded dramatically. You can, he was not able to go to college because of these severe shouting spasms. You can hear Professor Pal's voice in the background.
Dance comes, and that's why we are controlling diseases and all. The banging of the chest and all these things has come down. Just walk.
So this, and then post DBS you can see he is able to walk normally, and without the tics also have, vocal tics, loud, they also have improved. This is another case of Tourette syndrome. You have to remember these are taken for DBS only when the psychiatrist or the whole team says that they have not responded to the usual medical therapy. And this is post-op. You can see he has also improved significantly. So coming on to the newer advances which have occurred in this area is that brain sensing technology, which Dr. Praveen also mentioned, that now we can, the research has shown that there are beta bands. So there are particular firing pattern which correlates with the symptoms of Parkinson's disease. So at that particular firing pattern, if we give a stimulus or we give the voltage is given, then we can conserve the battery also, and the symptoms also will subside. So this is based on the local potential recording of the neurons in the subthalamic nucleus. And then closed loop DBS. Nowadays we have to program after DBS the voltage setting and all. If automatically based on the artificial intelligence or based on the feedback it is detected that there is abnormality and the machine itself gives the stimulation, then there is no role of the patient coming to the doctor again and again for the programming. So this also is almost going to be launched, and the results, and we may see in India also soon. And this is just to show the same thing, that high beta correlates with the slowness and stiffness. So this is the abnormal thing which has to be actually suppressed by giving the current at that particular moment. And the advances in the MRI, 7T MRI can further improve the targeting, improve the surgical outcomes, and there may be even the battery may miniaturized, and then it can be placed directly inside the scalp rather than having a big bulky battery below the clavicle. But what are the, I was going through the articles while reading, while preparing for this talk, and there are also, like in the morning we heard about that there can be, once this is connected to the internet and the remote programming is being developed. So somebody can do the programming, patient is in the village and we can approach that DBS through the Wi-Fi and try to do the programming. So it will be again connected. So imagine all those who have underwent DBS or such surgeries will be connected to the internet. So what are the chances, what are the risks? Again, the data of the patient is a thing which can be used by the in various ways which he or she may not like. And then there is a term brain jacking. So hijacking, you must have heard about hijacking. Now imagine if somebody takes the control of these stimulators, and this will apply to any of the implants which are there in the brain. So the brain itself can be taken control. These are the issues which are being raised actually for future, which has to be understood by all the stakeholders, clinician, patient, researchers, engineers who are preparing this condition. So DBS take home message: established therapy with refractory movement disorders, And future of DBS would bridge the gap by remote programming, automatic detection, and minimizing the doctor visits or hospital visits subsequently. So I would thank all my collaborators and my movement disorder team, which is led by Professor Pramod Pal and neurosurgeon Dr. Dwarkanath Srinivas and other members of our team at NIMHANS. Thank you so much.
Long live India and France friendship.